Welcome back to the deep dive. You know, if you or someone you care about has ever had to navigate the whole world of substance use treatment,
Mm-hmm.
you know that how fast it just becomes this fog of acronyms, right?
Mm.
IOP, PHP, ASAM levels, MIT. It feels so vast and complicated.
Oh, absolutely. And it's often at a time when you're already under immense stress.
Mm.
It feels less like a clear system of care and more like a maze you've been dropped into.
Exactly, a maze. And that's really what we're here to do today. We want to sort of dismantle that chaos. We're going to give you a structured roadmap.
We have some really solid source material that lays out the established professional frameworks for understanding recovery, and we can really break it down into two critical areas.
Right. So that's our mission for this deep dive. First, we're going to look at the external structure, that is, where treatment actually happens, all organized by how severe the need is.
And for that, we're leaning on the American Society of Addiction Medicine, or ASAM, and its whole concept of stepped care.
Step care. Got it. And then once we've mapped that out, we're going to shift completely. We're going to look inward.
Yeah, we'll explore the internal landscape, so how change actually happens inside a person. For that, we'll be digging into the stages of change model, it's just so useful for understanding why motivation can be so mixed and why recovery is almost never a straight line.
So you get the whole picture, the clinical logistics on one side and the psychological journey on the other. We're going to get into the four main levels of care, the really critical medical stuff like detox, and then, yeah, really unpack those 5 stages of motivation.
It's a lot to cover, so let's jump right in. We can start with the structure. Part 1, the structured world of care, ASAM levels.
Okay, so this ASAM approach, you hear it mentioned all the time. It seems like it's the gold standard in the field. What's the core idea behind this stepped care model?
The philosophy is actually pretty simple, but it's crucial. You can think of it like a staircase of intensity. We move from level 1, which is the least restrictive, most flexible option, all the way up to level 4, which is the most restrictive, medically managed inpatient care.
A staircase. I like that.
Yeah, and the whole point of the model, the real insight, is about efficiency and patient autonomy.
Which leads to that one fundamental principle you mentioned earlier, the sort of non-negotiable rule.
Exactly. The fundamental principle is that you should always use the least restrictive level of professional treatment that will still work, the one that allows the patient to get stable and stay stable.
So you don't automatically put everyone in a 30-day rehab.
God, no. You don't want someone in a hospital setting 24/7 if they have the stability and the resources to succeed with, just a couple hours of therapy a week.
That makes perfect sense from a comfort standpoint and definitely a cost standpoint. But is there a clinical reason not to put someone in a more restrictive setting just to be safe?
Oh, absolutely. And this is where the principle becomes really essential, not just, a nice idea. If you put someone in level 4, a hospital, when level 1 or 2 would have been enough, you're obviously running up huge financial costs.
Sure.
But it's more than that. You risk what you could call a kind of skill atrophy. Recovery, at the end of the day, is about learning to cope with real life, with real stress, real triggers. If you take a person completely out of society for too long when they don't need to be, they lose the chance to practice their new coping skills in real time. You can get this sort of institutionalization effect where they become more reliant on the external structure of the program than on their own internal resilience.
So the goal is always to get them back into their life.
As quickly and as safely as possible. So that least restrictive principle isn't just about freedom. It's actually a core part of the therapeutic goal. It's about skill development.
Okay, that reframes it completely for me. So if that's the principle, what are the big, high-stakes triggers that force you to move up that staircase? What tells you that level 1 or 2 just isn't enough anymore?
Well, there are really 2 major categories of instability that tell you a higher level of care is needed right away. The first one is serious medical complications.
Okay, what does that look like in practice?
This is anything that requires immediate, constant medical monitoring. So we're talking about acute conditions, severe, uncontrolled high blood pressure, for instance, or new signs of really bad liver damage, gastritis that might lead to internal bleeding, or, and this is a big one, any active withdrawal symptoms that pose a risk for seizures.
Things that an outpatient clinic just isn't equipped to handle.
Exactly. A level 1 or 2 setting doesn't have the staff or the technology to monitor someone's vital signs around the clock. If that's needed, you have to step up.
And the second trigger you mentioned was about mental health.
Correct. The second one is serious psychiatric complications. This basically means the person is an active risk to themselves or maybe to others.
So things like suicidal feelings.
Yes, but specifically persistent, severe suicidal ideation that requires that kind of continuous monitoring. We're talking 15-minute safety checks in a secure facility, or things like acute paranoia, an active psychotic break, or just a depression so severe that they can't even engage in therapy. If someone is actively suicidal, they need a locked, medically staffed level 4 environment, not a weekly appointment at a therapist's office.
It all comes down to stability then. Medical stability,
Yep.
psychiatric stability. If a lower level of care fails to create that or maintain it, that failure is the signal to step up.
Precisely. The system is designed to be pragmatic. If level 1 fails, you try level 2. If someone shows up from day 1 with these huge acute risk factors, you bypass the lower levels entirely and go straight to level 3 or 4 for their immediate safety.
Okay, that makes a lot of sense. So let's walk up that staircase. Let's start with those lower levels, the ambulatory care, where you're not living there full time. So
Yeah.
the foundation. Level 1, outpatient and aftercare.
Right. Level 1 is the most flexible and, frankly, the most widely used setting. It can vary a lot in how long it lasts. It could be a few weeks, it could be many months, or even years if it's being used as continuing care.
So this is the entry point for a lot of people.
It is, often for people with what we'd call milder substance use disorders,
Wow.
or it's the destination point. It's where you land after you've finished a residential program and you're stepping back into your life.
And what kind of services are we talking about here?
It's pretty holistic. You've got individual therapy, group counseling, family therapy is often a big piece, and medication management.
So what are the actual goals at this level? What are you trying to achieve?
The goals are really twofold. The primary clinical goal is pretty straightforward: to achieve and maintain abstinence, or in some cases, at least significantly reduce the harm from use. But the secondary goal is arguably the more important one for the long term, and that's about behavioral change. You're trying to help the person make personal and lifestyle adjustments to minimize their risk of relapse. You're equipping them to cope, effectively with the day-to-day stresses in their environment that probably contributed to their substance use to begin with.
And who's the right fit for level 1? What does a person need to have in place to have a good shot at succeeding with this minimal level of support?
They need a pretty high degree of stability already, both internally and externally, so they can't be at a significant risk for withdrawal. Their medical and mental health has to be stable and manageable with outpatient appointments. They have to be willing to cooperate. And crucially, they need to be able to maintain their abstinence with just minimal support. And this last point is maybe the most important. They must have a supportive recovery environment.
Let's talk about that. What does that mean, a supportive environment?
It's vital. If their partner, their roommates, their immediate family or social circle, if those people are actively using or encouraging use, level 1 is almost guaranteed to fail. You can't do 2 hours of therapy a week and then go back into a war zone for the other 166 hours and expect to succeed.
Right, which I imagine is the exact reason we need the next step up.
Yeah.
So let's go there. Level 2, non-residential addiction rehabilitation programs. This is where we hear about IOPs and PHPs.
Yes. Intensive outpatient and partial hospitalization. And these are a serious step up in commitment. They are intense.
But you're still going home at night.
You're still going home at night, which is why it's non-residential. But you are often in treatment for several hours a day, maybe 3 to 5 days a week. The whole program might last anywhere from 2 to 6 weeks. It provides a level of structure that's almost like a part-time job. It creates this enforced routine that's focused completely on recovery.
So where does this fit in the whole journey? Is it a starting point?
It can be, but it most often functions as this really critical bridge in the continuum of care. It's either a step down from a residential program from a level 3 or 4, which helps ease that transition back into the real world,
Okay.
or it's a step up when level 1 has been tried and it's failed. If that 1 hour a week counseling session isn't enough to interrupt the cycle of use, you intensify things and move them to level 2.
You said the environment was the key difference from level 1. So let's
Yeah.
really dig into that. If the person is still medically stable, minimal withdrawal risk, what makes them a fit for level 2 and not level 1?
It comes down almost entirely to those external risk factors. A person could be, medically and psychiatrically perfect for level 1, but if their home life, their job, their social circle is just incredibly triggering, what we call an unsupportive environment, they are facing an immediate high risk of relapse the second they walk out of the clinic door.
Can you give us a concrete example, like 2 different people?
Sure. Imagine 2 patients. Patient A is retired, lives alone, has adult children who are sober and really supportive. He's a perfect candidate for level 1. He has a safe place to go home to.
Right.
Now, patient B She's married to someone who is still actively using drugs, and they live in an apartment complex where there's a lot of drug activity. Patient B is being sent back into chaos every single
I
night.
see.
For patient B, the intense daily structure of level 2, say 4 hours a day, 4 days a week, just immersed in a recovery-focused world, that structure acts as a temporary daily substitute for a healthy support system. It just floods their system with recovery tools and coping skills, which allows them to build up their internal defenses even while they're going back to a toxic situation every evening.
So that daily dose of intensity is what breaks the cycle.
It's what interrupts the cycle and helps manage that really high relapse potential that's coming from their environment, not just from within them.
So level 2 is really the clinical world acknowledging that sometimes your environment is the biggest part of the problem, and it tries to insulate you from that, at least for a few hours every day.
That's the perfect way to put it. And the sheer time commitment is designed to help that person rapidly learn the skills they need to survive when they are alone in that environment.
Okay, now we move into the most intensive settings where you are living at the facility, levels 3 and 4. Inpatient and residential care. This covers everything from a short-term rehab to, these long-term communities.
Right. And the defining feature here is 24-hour observation and monitoring. That's essential when a person's stability or their basic safety is severely compromised. And these programs, they vary a lot. Some are in hospitals, some are freestanding facilities, and they're often specialized.
Specialized how?
You'll find programs specifically for, say, a certain severity of addiction, or gender-specific programs, programs for people involved in the criminal justice system, or for those with co-occurring mental health disorders.
Let's start with the short-term addiction rehabilitation programs. I see here the stays can be quite short, sometimes less than 2 weeks. What's the purpose of that?
The duration is, unfortunately, often dictated more by insurance and funding than by clinical need, which is why you see these shorter cycles. Now, the first choice for rehab, assuming there's no acute medical crisis, is always a non-hospital-based program.
Okay. And when are they recommended?
They're recommended when one of two things is true. First, if the less intensive settings, level 1 and 2, have already failed. Or second, if the addiction is just so severe that it requires a structured, complete break in the cycle, a total interruption to get them stable and build some initial motivation.
So if the relapse cycle is just immediate and severe, you have to physically remove the person from their environment, even if they're not having, say, a medical emergency.
That's exactly right. A really high potential for immediate relapse or a home environment that's just flat out dangerous. So dangerous that even going home from an IOP every night is too risky. That's when you need level 3. The focus is on initial stabilization, education, a lot of intensive group therapy. It's a rapid, focused intervention.
And it's noted here that the main focus is still on alcohol and other drugs, though tobacco is increasingly part of the conversation.
Yes, while more and more residential programs are going entirely smoke-free, the core clinical work is usually centered on the substance that brought the person there. Recognizing that overall wellness might include quitting tobacco, but the immediate life-threatening crisis is usually the primary drug of dependence.
Okay. Now for the much deeper commitment, long-term addiction rehabilitation programs. Who is this level of care for? Who needs that much time and intensity?
These programs are really for individuals with severe, deeply entrenched patterns of addiction, and this is key, significant impairment in their life. This goes way beyond just how often they use.
So you're talking about more than the addiction itself.
We're talking about people who lack the basic infrastructure for a stable life. Little or no social support, huge gaps in their vocational skills or education, a long history of multiple rapid relapses right after finishing shorter treatments, and often chronic legal problems that are all tied up with their substance use.
It sounds like for these individuals, recovery isn't just about stopping a drug. It's about fundamentally rebuilding their entire life, their identity, their practical skills from the ground up.
It absolutely is. The focus shifts from just stopping use to achieving sustained recovery through a complete life change. These programs help a person stay sober by addressing really complex personality issues, social deficits, lifestyle factors, things like halfway houses, special programs for, say, women with children, and historically the big one was therapeutic communities, or TCs.
And you mentioned there's a critical point here about TCs. The way they operate has changed a lot.
It has dramatically. Historically, therapeutic communities were famous or infamous for requiring these massive commitments of up to 2 years. It was a true immersion in a new way of life.
2 years is a long time.
A very long time. And today, we see that trend has shifted significantly. Modern TCs are more likely to run for several months, maybe up to a year. And this is partly due to, clinical evolution, but it's also due to huge systemic pressures.
Like funding.
Like funding. Reduced government funding has meant that fewer of these really long, comprehensive programs are even available anymore. Access is getting harder and harder,
Yeah.
and this creates a real dangerous gap for the very population that needs the most support and the most time to rebuild their lives.
A gap in the continuum of care, right where the most vulnerable people need it.
It's a serious systemic problem. But regardless of the level, the sources are all very clear on one thing. Continuing care is essential once the main program is over.
That's non-negotiable.
It's non-negotiable for any lasting success. It's the safety net. It's the practice field. It lets the person keep focusing on recovery issues and stay connected to support while they're out there in the real world, trying to get a job, fix relationships. That transition period is so high risk, and continuing care, often at a level 1 setting, is what manages that risk.
Okay, we've mapped the external world of treatment. Now let's pivot to the medical side of this, which is often the first door people have to walk through. This is part 2. The medical side of recovery, detox, and medication.
Detox is, for many people, it's the absolute starting line, and we should be really clear on what we mean by it. Detoxification is the medically managed process of tapering off a substance using specific medications to suppress or reduce the withdrawal symptoms.
And those symptoms can be pretty severe.
They can be uncomfortable, and in some cases, they can be fatal.
So where does this happen? It's not something you can just do at your local clinic.
No, the setting is critical, and it depends entirely on the level of risk. Detox can happen in a dedicated addiction facility, a psychiatric hospital, or a general medical hospital. The location is really determined by the severity of the withdrawal risk and if there are any other co-occurring disorders that need to be managed at the same time.
So what are the red flags? The circumstances that absolutely require a person to be under medical supervision for detox.
Medical detox is mandatory if there's a documented history of severe physical dependence, or if there's current evidence of, or even just significant potential for, life-threatening withdrawal complications.
Like what?
Like seizures or delirium tremens, the DTs. Also, if the person has serious, unmanaged suicidal thoughts, they need to be in a safe place. And if they have other medical or psychiatric problems that need to be monitored during the withdrawal process, then a hospital-based setting, a level 4, is the only safe option.
Let's really hammer this point home because the sources are so strong on this. The danger of quitting cold turkey. Which substances pose that unique physiological threat?
This is a warning that absolutely needs to be heard loud and clear. Withdrawal from alcohol or barbiturates is uniquely dangerous and potentially fatal.
Why those specifically?
Well, when a person is physically dependent on these substances, the brain's GABA system, which is your main braking or inhibitory system, is constantly being suppressed by the drug. When you suddenly take that drug away, the entire nervous system rebounds. It goes into this hyper-excitable, uncontrolled state.
It sounds like a neurological storm.
That's a great way to describe it. It's a state of excitotoxicity. And that's what causes the seizures, the massive spikes in blood pressure, hallucinations, and in the worst cases, total systemic collapse or fatal DTs. For dependency on those specific substances, medical evaluation and supervised detox are not just a good idea, they are required for basic safety.
And beyond the physical danger, the sheer discomfort must be a huge barrier.
Oh, it's immense. The pain and agitation create this incredibly powerful drive for the person to just use again, simply to self-medicate the symptoms and make it stop.
So the message is, if someone has a severe dependence on alcohol or benzodiazepines, just deciding to stop and walk into an AA meeting is not the safe way to start.
It is the least safe strategy. It can easily result in an immediate medical emergency. You need medication to gradually and safely bring that overexcited nervous system back into balance. Detox itself might only last a few days, but the medical management, especially tapering off the medications, often continues well after they've left the facility.
And the sources also make a really important clarification. Detox by itself is not treatment.
So critical to understand. Detox is just the medical stabilization. It's the beginning. It is not the solution. Detoxification has limited value if it is not immediately followed by other clinical treatments, rehab, outpatient therapy, mutual support programs.
You've just put out the fire.
Exactly. You've drained the floodwater from the basement, but you haven't done a single thing to fix the broken dam. You haven't addressed any of the underlying causes or helped the person develop any new coping skills.
Okay, so after that acute crisis is managed, let's talk about the longer-term medical support. Medication-assisted treatment, or MAT. This seems to be a huge tool, especially for opioid use disorder.
MD is recognized pretty much globally as an essential evidence-based part of care, and it works best when it's provided alongside good education and counseling. For opioid use disorder, or OUD, we have three major pharmacological tools, and they all work in different ways.
Okay, let's start with the one that's been around the longest, methadone maintenance, or M.
Right. Methadone is what we call a full opioid agonist. So if you think of your opioid receptors like a car's accelerator, methadone puts the car into full throttle, but it holds it at a steady, controlled speed.
So it activates the same receptors as heroin.
It does. It activates the same receptors as heroin or oxycodone, but because it's tightly regulated and very slow acting, it prevents withdrawal and it satisfies the craving, but without producing that dangerous rapid high or euphoria. It's typically used for people who have tried and failed multiple times to quit other opioids.
And the goal can be either to wean off eventually or to just maintain a stable dose for months, even years. What are the proven benefits of that?
The benefits are massive. Methadone maintenance dramatically reduces illicit opiate use, it lowers rates of crime associated with drug seeking, and it helps people stabilize their lives. It allows them to hold a job, to be parents, to participate in their community. But there's a big logistical hurdle.
Which is?
It has to be dispensed daily at a highly regulated, specialized treatment center. You have to show up every single day.
And that logistical challenge is exactly why the next drug, buprenorphine, which people might know as Subutex or Suboxone, why that was such a revolution in treatment.
Buprenorphine was a complete game changer, both because of how it works and how it's delivered. Mechanistically, it's a partial opioid agonist. So if methadone is the full throttle, buprenorphine is like a safety-governed throttle.
Okay, what does that mean?
It means it satisfies the receptors just enough to prevent withdrawal and cravings, but only up to a certain point. It has a ceiling effect. This makes it much, much safer in an overdose situation because the respiratory depression, which is what kills people, it plateaus. It doesn't keep going up and up.
And the delivery method is the other huge advantage.
This was the clinical breakthrough. Buprenorphine can be prescribed by office-based physicians, any doctor who gets a special waiver. This means patients don't have to go to a special clinic every day. They can go to their family doctor and pick up a prescription at a normal pharmacy.
That's a huge difference in accessibility.
It massively improves access. It reduces the stigma of lining up at a clinic every morning. And it just makes treatment far more practical, especially for people who are trying to hold down a job.
The sources also mention that it's less likely to be diverted or sold on the street than methadone.
That's generally true, and it's usually because of how it's formulated. The most common form, Suboxone, actually has naloxone mixed in with the buprenorphine.
And naloxone is the overdose reversal drug.
Exactly. So if someone tries to crush up a Suboxone pill and inject it to get a high, that naloxone is immediately activated and it throws them into instant severe withdrawal. It's a built-in abuse deterrent, which significantly reduces its street value compared to pure methadone.
Fascinating. Okay, the third option is naltrexone, which is sold as Revia or the monthly shot Vivitrol. How does this one work? It's different again.
Completely different. Naltrexone is an opioid antagonist. So instead of activating the receptors at all, it's like a wall. It blocks them.
It's a blocker.
It's a blocker. If you take naltrexone and then you try to use an opioid, nothing happens. The euphoric effects are completely blocked. It takes the reward out of using. So for someone who is really committed to abstinence, it's like a biochemical safety belt. It ensures that even if they have a slip, they won't feel the high. It's a great option for OUD, and it's also used for alcohol use disorder to help reduce cravings.
And finally, the immediate life-saving tool in this space, Narcan, which is naloxone.
Yeah, naloxone is just non-negotiable for safety planning for anyone with OUD. It's not a treatment for the disorder itself, but it's the emergency reversal medication. It rapidly knocks opioids off the receptors and can reverse a potential overdose in minutes.
And the recommendation is that everyone around the person should have it.
Absolutely. The strong recommendation is that family members, friends, even other drug users are trained and equipped to administer it. It can turn a potential fatality into a reversible medical event.
We've covered the external structure, the medical side. Now we need to make that shift inward, because a program is only as good as the patient's mindset. This is part 3. The internal journey, motivation, and the stages of change.
And this model is so important because it teaches us that change isn't like flipping a switch. It's a process. It happens in 5 stages, and here's the absolute key insight. It is not linear.
Right. It's not a straight line from A to B.
Not at all. People often move 2 steps forward, get stuck, maybe cycle back 1 step, and then jump forward again. It normalizes relapse and setbacks as part of the process, not as some kind of personal or moral failure.
Okay, so let's walk through the psychological landscape of these 5 stages. We start at the beginning with stage 1, pre-contemplation.
The pre-contemplation stage is really defined by unawareness, or more often, denial. The individual is resistant to the idea of change. They genuinely don't believe they have a problem. Or, if they do admit to some problems, they blame them on external things, their boss, their spouse, bad luck, anything but their own substance use.
So they have no internal motivation to change.
None, because they haven't internalized that there's a problem that needs fixing.
So if someone is in that stage, what does an intervention even look like? You can't just force them into therapy for something they don't believe is an issue.
You really can't. Intervention at this stage is usually very gentle. It's aimed at just raising awareness, planting a seed of doubt. The goal is not to force them to commit to anything, but just to create a little bit of dissonance in their thinking. If a professional tries to jump ahead and say, book them into a rehab, it's going to be met with huge resistance, hostility, and they'll probably just walk out. You have to meet them where they are.
Which brings us to the next stage, that shift. Stage 2, contemplation. What happens here?
Contemplation is the moment that internal light switch finally starts to flicker. The person acknowledges, okay, maybe I have a problem, and that is a profound shift away from denial. But, and this is a big but, they are sitting squarely on the fence.
So they see the problem, but they're not ready to act.
Exactly. They see the need for change, but they aren't committed yet. They're thinking about taking action sometime in the next 6 months. They're weighing the pros and cons.
The costs of quitting versus the benefits of continuing to use.
Precisely. They're in this state of chronic ambivalence. They'll say things like, yeah, my drinking is causing fights with my wife, but it's also the only way I know how to relax after a long week. Or, I know I should quit, but all my friends use and I don't want to be lonely. The best intervention here is something like motivational interviewing, where you help the person articulate their own reasons for changing instead of you telling them why they should.
Okay, that ambivalence gets resolved enough to move to stage 3, preparation. How is this different from contemplation?
Preparation is the commitment to take action, and usually within the next month. The person has moved from just thinking about change to actively planning it.
So they're taking concrete steps.
Yes. They might be calling treatment centers, making a doctor's appointment for a detox evaluation, or, and this is a big one, telling their family and close friends that they plan to stop.
Yeah.
That public declaration is a way of creating accountability.
Now, you brought up a really crucial insight that applies here, that motivation is almost always mixed.
This is one of the most powerful and compassionate parts of this model. Even when they're in the preparation stage, actively planning to quit, you cannot expect them to have 100% motivation. A part of them still wants to use, whether it's for comfort or ritual or escape. They're still deeply ambivalent, but finally, the desire to change has started to outweigh the desire to stay the same.
And if a therapist doesn't get that, they could really misread the situation.
They will completely mismanage the client's struggle. If you expect perfect motivation, you'll be frustrated. But if you recognize that this mixed feeling is a normal feature of this stage, not a bug, it helps everyone manage their expectations.
Then comes the hardest part, stage 4, action.
The action stage is defined by that commitment to actually stop using. This is the period of intense, active change, often lasting about 6 months, where the person is getting sober or clean. And as we talked about, if they are physically dependent or at high risk for complications, this stage must start with a medically supervised detox.
And the sources are very clear that this action stage is about so much more than just not picking up a drink or a drug.
Oh, it's a phase of complete cognitive and behavioral overhaul. They are actively working to change their thinking, their emotional coping skills, their very self-image. This is where they have to tackle the nuts and bolts issues of recovery, the day-to-day practical skills they need to stay sober once they leave the safety of the clinic.
Let's spend a minute on those nuts and bolts. What are the critical survival skills people are learning in the action phase?
They're incredibly practical and also incredibly hard. First, learning to cope with thoughts and cravings. This means learning to recognize a craving as just a temporary thought, not an order you have to follow, and having practiced distraction techniques ready to go at a moment's notice. Second is navigating high-risk people, places, and things. This often means making really hard choices, like changing your phone number or avoiding entire parts of town.
And what are the emotional side of things?
That's huge. They have to learn brand new ways to handle upsetting feelings. For years, their substance was probably their main tool for dealing with anxiety or boredom or sadness. In the action phase, they have to replace that one destructive tool with a whole toolbox of healthy ones. Exercise, meditation, talking to someone, or just learning to tolerate the discomfort until it passes.
Wow.
And on top of all that, they're addressing the relational damage, the family problems their use caused, and trying to build structure and support into their life, often through mutual support programs like AA or NA. The action stage is it's exhaustion, it's vigilance, and it's profound learning all at the same time.
Which then hopefully leads to stage 5, maintenance or relapse prevention.
Right. Maintenance is the indefinite, ongoing stage where the person is working to sustain all the positive changes they've made. They've come to accept that recovery isn't a 30-day fix. It requires long-term vigilance. The challenge here shifts from immediate crisis management to long-term life balance.
So what's the main psychological work being done in maintenance?
It's really twofold. First, identifying and managing their personal relapse warning signs. Relapse is very rarely a sudden event out of the blue. It's a gradual process. So the person has to learn to spot those early signs. Maybe they start isolating, or they feel emotionally exhausted, or they start slipping back into old, resentful ways of thinking, and then immediately activate their relapse prevention plan.
And the second part?
The second part is achieving life balance. They're actively working to balance all the different areas of their life, their work, their relationships, their physical health, their spirituality, because success and well-being in these areas build self-esteem, and that self-esteem acts as this powerful buffer against going back to the old behavior.
It's interesting, the sources note that while there's a theoretical termination phase, the real focus in practice is on maintenance as the ongoing goal. Why is that?
Termination would imply that the risk is gone completely, that the person never even has to think about it anymore. For severe addiction, that's often seen as an impractical or even a misleading goal. By focusing on maintenance, we emphasize that the effort is active, it's continuous, and it becomes an integrated part of a healthy, successful life. It's about acknowledging that the underlying vulnerability might always be there, and that requires lifelong vigilance.
Okay, so understanding these stages is obviously key to setting goals that are actually achievable.
It's everything. The goals have to be super personalized. They have to be based on the severity of the problem, the person's current stage of motivation, and the life changes that they themselves genuinely want to make.
And this is where working with a therapist is so important.
Absolutely. The therapist's job is to guide the client in defining specific, measurable goals and the steps to get there. But sometimes the therapist has to advise the client to go in a direction they might initially resist, especially if the risk of harm is really high.
Can you give us an example of that? When would a therapist advise total abstinence, even if the client says they want moderation?
There are two classic clinical situations. First, if a person has a history of severe alcohol use disorder, the professional literature is overwhelming that moderation is not a viable or safe long-term goal. So even if the client comes in saying they just want to learn to control their drinking, the therapist will advise them to work toward total abstinence because the risk of a full-blown relapse is just too high.
And the second situation involves using more than one substance.
Exactly. Let's say a client agrees to stop using their primary drug, like cocaine or heroin, but says they still want to be able to drink alcohol or smoke marijuana. The therapist is going to strongly advise total abstinence from all psychoactive substances.
Why is that?
Because using those secondary substances significantly lowers your inhibitions and very often acts as a powerful gateway or a trigger that leads right back to the primary, more dangerous drug. Abstaining from everything just creates the clearest, safest protective barrier.
So the therapist is always coming from a safety-first perspective, even if that's not what the client wants to hear at first. What if someone is really early in the process, in that contemplation stage, and they truly don't know what their final goal is?
That ambiguity is totally normal and it's healthy at that stage. And the sources give a really wonderful intermediate goal for that situation. If they're unsure, the initial goal can simply be deciding what I want to change about myself and my alcohol tobacco, or drug problem.
Oh, love that.
It's perfect, right? It's a goal they can achieve almost immediately. It moves them successfully out of contemplation and into preparation, but it doesn't demand this impossible, overwhelming commitment to lifelong sobriety right at the start. It honors their ambivalence.
We have the external structure, we have the internal psychological movement. Now let's get really practical. Part 4, practical tools for motivation. The things that help you put all these insights into practice day to day.
And one of the most powerful tools for this is what's called the decision-making matrix, sometimes called a decisional balance worksheet. Its whole purpose is to force clarity onto that feeling of ambivalence we've been talking about.
So how does it work? How is it structured?
It's basically a grid. It makes the person systematically analyze the immediate and the long-term consequences of two competing decisions. The decision to quit using versus the decision to continue using.
Okay.
So you look at the pros and cons of quitting, the immediate good things, immediate bad things, long-term good, long-term bad. And then, and this is the important part, you do the same thing for continuing to use.
And I imagine this is where it gets really challenging psychologically.
Yeah.
We assume that the continue use side of the worksheet should just be full of negative things, but for the person filling it out, that's not the reality.
Exactly. This is the moment that requires radical self-honesty. Most people are deeply ambivalent for a reason. They can often make a very strong case for continuing to use. Why? Because the substance, no matter how much damage it caused, it provided something functional for them. It served a purpose.
So they have to write down the good things about using.
They have to acknowledge and write down the perceived benefits, the gains they got from it.
What are some examples of those gains? What are people afraid they're going to lose if they quit?
Oh, it can be so specific. For someone with severe social anxiety, maybe alcohol was the only thing that allowed them to walk into a party and feel like they could talk to people. It gave them a temporary feeling of confidence. For someone with deep trauma, a substance might have provided 30 minutes of guaranteed silence in their head, a break from the intrusive thoughts.
So they're afraid of losing their only coping tool.
Their only known coping tool. For others, the gain might be a ritual they enjoy, or the camaraderie of the group they use with. If you don't acknowledge what you're losing, you're fighting an invisible battle.
You're leaving a vacuum.
Precisely. The matrix forces them to bring those perceived gains into the light. And the task isn't to pretend those gains didn't exist, but to understand them, to grieve them, and then to actively work on finding healthier ways to get those same needs met. The goal is to create a decisive imbalance in that matrix, to tip the scales so heavily toward change that the decision becomes clear.
But even after you've made that decision and you're in the action or maintenance phase, motivation isn't a constant. It's going to dip. So when that commitment starts to waver, what's the first thing you should do?
The first rule, the most important one, is you have to break the isolation. Low motivation is most dangerous when it's kept secret. The person needs to immediately talk about those feelings with a trusted confidant, their therapist, their sponsor, someone in their support group. Just saying it out loud takes away so much of its power, and it activates your support network.
And beyond just talking about it, the sources lay out this really powerful, active checklist of strategies to get that commitment back. Let's walk through them.
Okay, first, review your reasons for quitting. This sounds so simple, but it's incredibly powerful. It reconnects you to the pain that drove you to get help in the first place. It fights that tendency we all have to romanticize the past. If you look at a list that says, I almost lost my job, or my kids were scared of me, it brings the urgency right back.
Okay. Second, remind yourself that low motivation is temporary.
This one is all about normalizing the experience. It's telling yourself, I am not failing, I am just having a feeling, and this feeling will pass. It gives you perspective, and it stops a temporary dip in mood from turning into a full-blown relapse.
Third, review the benefits you've already experienced in recovery.
Yes. This is so key for fighting that immediate self-criticism. So have you been sleeping better? Have you saved any money? Is your blood pressure down? Focusing on those tangible, concrete gains reinforces the immediate reward of sobriety, which can sometimes feel a lot slower than the immediate reward of the substance.
Fourth, identify additional benefits from continued recovery. This one looks to the future.
It shifts your focus from what you've already gained to your future potential. What kind of career success could you have? What level of trust could you rebuild with your family? It gives you a compelling vision to work toward.
Fifth, remember the problems caused by your use. This feels like the flip side of reviewing your reasons for quitting.
It is. It's the counterpoint to nostalgia. It's important to explicitly recall the negative consequences, the legal trouble, the shame, the physical pain. Don't let your mind start to edit the past and minimize how bad it really was.
Sixth, think about the meaning of recovery for your children or other important people.
This one is huge. For a lot of people, especially parents, that external accountability can be an even stronger motivator than their own internal desire. Framing your recovery as a gift you're giving to your loved ones or a legacy you're building for them, it just adds immense weight and urgency to the task.
And finally, seventh, ask others in recovery what they did during periods of low motivation.
This is about drawing strength from the community. It fights that feeling of terminal uniqueness, that sense that I'm the only one who struggles this much, and it gives you practical, tested strategies from people who have been exactly where you are and have made it through. Using these 7 points proactively can turn a slump into a structured exercise in strengthening your recovery.
We've done it. We've mapped the whole journey from the big clinical macro structure of the ASAM levels all the way down to the psychological micro skills you need for daily survival.
To sum it all up for you, our learner. On the external front, we established that ASAM principle of stepped care. Always start with the least restrictive setting, level 1 outpatient. Unless specific risks, medical, psychiatric, or environmental force you up the ladder to level 2, 3, or 4.
We hit the critical medical piece hard. That supervised detoxification is not optional, it is mandatory for dangerous withdrawals, especially from alcohol and barbiturates. And that MAT options like buprenorphine, because it's office-based and so accessible, have just fundamentally changed how we treat opioid use disorder.
And then internally, we navigated the Prochaska stages of change, really stressing that change is not a straight line. The journey starts with pre-contemplation, moves through that ambivalent contemplation stage, and demands this intense focus on the nuts and bolts of life change during the action and maintenance phases. It gives a common language to a process that can feel so chaotic.
It takes it from feeling like you're just going crazy to, oh, okay, I'm not broken, I'm just in the contemplation stage. And there's a next step for this.
Exactly. And that actually brings us right to our final thought. The deep power of that decision-making matrix we talked about is so often overlooked. It's easy for anyone to list the negative consequences of substance use. That's the simple part. But the truly courageous work, and often the most essential first step toward a recovery that will actually last, is to honestly identify and write down the perceived benefits of the behavior you want to leave behind.
Acknowledging what the substance gave you.
Yes. For the person riddled with anxiety, the substance gave them a moment of silence. For the deeply lonely person, it gave them temporary social armor. If you try to quit without first acknowledging what you perceived you were gaining from it, you leave this functional, unmet need in your life. You create a vacuum. And addiction will always try to rush back in to fill a vacuum.
So the challenge for you, the learner, isn't just to list the problems. It's to understand the function the substance was serving and then find a healthy, sober alternative to meet that same core need. And that honest assessment is what strengthens the entire case for recovery.
It is the absolute foundation for lasting change.
A crucial and difficult challenge. And that is a wrap on this deep dive. We hope this roadmap proves to be invaluable on your journey of learning.